He or she needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please just cross out the number or just don't fill the form. Other members of the same clinic are able to assess the presentation. The assessment will be verified. All the presentations and the discussion must be run in English. We kindly ask the jury to assess the scientific value, way of presenting, discussion, and all contribution from the points 1 to 5. When the session ends, we will kindly ask you to give the cards back or send us the full the form to the session coordinator. And please send it via email at the same address or just click the send button. To begin, I think we can start with the first presentation. So I would like to ask the first presenter of the work, the analysis of the prevalence and clinical picture of lactose and fructose intolerance in children. Please welcome.
And can I ask on the first slide? Okay. Dear colleagues and jury, today I have pleasure to present you our paper, Analysis of the Prevalence and Clinical Picture of Fructose and Lactose Intolerance in Children Hospitalized at the Department of Pediatrics, Medical University of Silesia and Katowice. As a quick introduction, prevalence of lactose intolerance is about 20 to 30% of Polish population. On the other hand, fructose intolerance, 40% in the world's population. As you can see, symptoms of both intolerances are similar, and the diseases which can be accompanying lactose intolerance is intestinal infection, SIBO, celiac disease, Crohn's disease, nutritional allergy, or IBS. The diseases which may coexist with fructose intolerance is IBS or chronic intestinal disorders. Both diseases can be diagnosed with hydrogen breath test with lactose or fructose. Additionally, the tests which may diagnose lactose intolerance is lactase activity in the small bowel mucus, stool activity CDT test, provocation and elimination test, and genetic test. Also, other diagnostic methods for fructose intolerance is provocation and elimination test and genetics test. The aim of the study was to analyze the prevalence and the clinical picture of lactose and fructose intolerance in patients treated at the Department of Pediatrics and the Pediatric Gastroenterology Outpatient Clinic, Medical University of Silesia and Katowice. 206 children with diagnosed lactose and or fructose intolerance were taken into analysis, and the treatment data was analyzed retrospectively. Our study group consisted of 52% of females and 48% of males, aged between 3 to 17 years, and the mean age was 10 years. According to the graph, in lactose intolerance group and both lactose and fructose intolerance group, females were larger group. On the other hand, in fructose intolerance group, males were more numerous. And the hospitalized children, the ratio of hospitalized children is 67%. Also, our study group consisted of 43% in fructose intolerance, 31.4% in lactose intolerance, and 23.3% in fructose and lactose intolerance. The most repeating symptoms are abdominal pain, diarrhea, constipation, and vomiting. As you can see, these symptoms are not specific. According to the graph, we can notice that the most common symptom in all groups, fructose intolerance, lactose intolerance, and both at the same time, is abdominal pain. Other symptoms also occurred with a similar frequency. Now we can move on to the nutritional status, which was significant in our study. And as you can notice, it was diversified. About 10% of patients had short stature. Also, 10% of them were underweight, while 13% of patients were overweight or obese. Now, on the following two slides, I would like to present you a comparison between BMI and height according to the groups lactose intolerance, fructose intolerance, and both at the same time, fructose and lactose intolerance. The population of patients with normal BMI, it's about 65 to 68%. Similar conclusion we can notice in height according to those three groups, and the percentage of patients with normal height fluctuates between 72 to 75%. We also analyzed laboratory parameters, and in the most cases, parameters like alanine transaminase, asparagate aminotransferase, GTP, or white blood cells were normal. We also noticed that about 8% of our patients had reduced a level of vitamin D, and it was most frequently in fructose intolerance group. Now we can move on to the radiological and endoscopic findings, and about 80% of our patients were examined by abdominal ultrasound examination, and it didn't show any significant abnormalities. It revealed only large bowel gases, feces, and large lymph nodes, and thickening intestinal wall. The most common comorbidities with lactose and fructose intolerance are allergies, gastritis, celiac disease, and psychiatric disorders. And the occurrence of celiac disease was mostly found in lactose intolerance group. Also, allergies were found in 26.7% of our patients, and mostly it was food allergies. The biggest ratio of allergies was shown by fructose intolerance group. And to sum up, lactose and fructose dietary intolerance can cause unexplained gastrointestinal symptoms and should be considered into differential diagnosis. In saccharose intolerance, abdominal pain is the main symptom. The nutritional status of patients with saccharose intolerance is within normal range, and it's important to highlight the frequency occurrence of allergies in saccharose intolerance. Thank you for your attention, and feel free to ask any questions.
Thank you for the presentation, and now let's move on to the questions. Do you have any question, the esteemed jury, or maybe someone from our public audience?
Well, I don't have a question. I just want to congratulate you for a beautiful presentation. And for me, it's really a little bit astonishing that some of these children were even obese, which means that you really can consider this this sickness even it not underweight children, but also in the obese one. How would you explain that? In spite of all these problems, they were obese.
It mostly because of the clinical symptoms which were presented with in our patients, and it's common situation when we are choosing lactose and fructose intolerance test to check up.
So which would we call a dominating syndrome? The abdominal pain, after all, if I understood.
Yes, it was the most common symptom in all our patients, and about 50% of them was the abdominal pain was only 50.
The only
only symptom, but in 50 patients of this 206.
Mm-hmm. Okay, thank you. Very nice presentation. Thank you very much.
Thank you very much.
Congratulations for nice presentation. I have a very similar question because 10% of patients were underweight. What percentage of this patient had celiac disease? Because 6.2 patients had celiac disease and 10% had.
Yes, you are right, but I don't really remember which of them had celiac disease. Okay. And I think I need to check this.
Okay, thank you.
Thank you for your very nice presentation. I have a very difficult for my specialty question. Do you remember if these children, they have any history of some gastrointestinal problems during the very early neonatal life?
Some of them was confirmed with SIBO earlier. But mostly it was diagnosed with the fructose and lactose intolerance at the hospitalization at the department.
And the abdominal pain and colic, they were noticed in the history?
Can you repeat?
Colic and abdominal pain, very typical for infants, and sometimes it's a nightmare for parents. So do you remember if they were very much emphasized in the history of these children?
I don't really remember that.
Okay, thank you very much.
Thank you very much.
And with this question, we're out of time. Thank you very much. Thank you for the presentation.
Excuse me, just one short question. What was your contribution? Because we have to rate that.
What was your own contribution to this work?
You collected the data of all the patients?
I collected the data in the department, and I was at the presentation as a presenter, mostly.
Okay, thank you.
Thank you very much. And now let's move on. I would like to start with another presentation, glaucoma secondary to Strat-Weber syndrome in children, surgical treatment outcomes. Please welcome our presenter.
Honorable jury, it is my pleasure to present to you today our study about surgical management of glaucoma secondary to Strat-Weber syndrome. Let me begin by noting that Strat-Weber syndrome is a rare neurocutaneous disease that is characterized by vascular malformations in a triad of symptoms, including portwine stain, facial hemangioma, angiomatous lesion of leptomeninges, and eye abnormalities, of which glaucoma is the most common. It affects 1 in every 50,000 newborns and is caused by a somatic mutation in the GNAQ gene. This mutation is not hereditary and occurs sporadically. Our study group consisted of 26 children, including 16 boys and 10 girls. The age range fluctuated from newborns to 12-year-olds, and out of 26 children with confirmed diagnosis of Strat-Weber syndrome, 54% were diagnosed with glaucoma. The mean intraocular pressure at the time of the first examination was 15 millimeters of mercury in non-affected eyes and 33 millimeters of mercury in eyes with glaucoma. Among glaucoma patients, 9 were diagnosed with unilateral and 5 with bilateral glaucoma. 8 patients underwent various surgical procedures, and 6 were treated only with anti-glaucoma medications, including dorzolamide, timolol, and brimonidine. In our study, there were 3 different anti-glaucoma surgeries that patients could undergo. Trabeculectomy, which involves removing part of the trabecular meshwork and creating a new escape route for the aqueous humor. Transscleral cyclophotocoagulation, in which diode laser destroys the pigmented ciliary body epithelium, thereby decreasing the production of the aqueous humor. and cyclocryotherapy, in which by freezing the ciliary body, it reduces the production of the aqueous humor. Measurements were taken before surgery, 6 days, 15 weeks, and 12 months after surgery. During the first control, the average intraocular pressure values decreased in each of the study groups, with the largest decrease of 54% observed in patients after trabeculectomy. In the case of this procedure, during the second period of control, intraocular pressure slightly increased, while it continued to decrease for cyclophotocoagulation and cyclocryotherapy. And at 12 months after the procedures, intraocular pressure for cyclophotocoagulation and cyclocryotherapy groups increased above the upper limit of norm, while it decreased for trabeculectomy group. In the statistical analysis, we examined the effectiveness of the discussed therapies, measured with the average intraocular pressure before and at 12 months after the procedures. Regarding trabeculectomy, we obtained a p-value of 0.002, thereby at the significance level of 0.05. There are grounds to claim that the intraocular pressure after trabeculectomy is significantly lower than before the procedure. Regarding cyclocryotherapy and cyclophotocoagulation, we obtained the p-values of 0.59 and 0.17 respectively. Thereby, the effectiveness of this method of treatment has not been confirmed. In addition to intraocular pressure, the second indicator of effectiveness we considered was the need for additional procedures or medications after surgeries. Regarding trabeculectomy, such need was observed in 28% of patients, whereas in the matter of both cyclophotocoagulation and cyclocryotherapy, all of the patients required additional procedures. It's worth to mention that all of the patients in the trabeculectomy group who required such procedures underwent surgery without the use of mitomycin C, which may indicate that the better results could be achieved with the trabeculectomy with the use of mitomycin C. And in conclusion, I should just like to say that every child with suspected Sturge-Weber syndrome should be consulted by an ophthalmologist as soon as possible, as symptoms of high intraocular pressure in children are non-specific, and untreated glaucoma could have a very serious and irreversible consequences. And patients with Sturge-Weber syndrome without glaucoma should have a regular eye checkups, as glaucoma can develop later in life. And managing glaucoma associated with Sturge-Weber syndrome is challenging, as it shows very poor response to the standard pharmacological treatment, possibly to its complex etiology, including the pathology of the unconventional aqueous outflow. And the best results in surgical treatment of glaucoma is associated with this Sturge-Weber syndrome is achieved after trabeculectomy with mitomycin C, both in terms of lowering intraocular pressure and reducing the use of anti-glaucoma medications. However, procedures such as cyclophotocoagulation or cyclocryotherapy are less invasive, which may be associated with a lower risk of adverse events. Thank you for your attention. If you have any questions, feel free to ask them.
Thank you very much for this presentation. And now let's move to the discussion. Do our jury or someone out there have any questions? So maybe I'll ask you about your own contribution to this work first.
We revised the medical records and collected the data, and we did the analysis of the data.
Okay, thank you.
Thank you.
Yes.
Maybe some neurologists would ask some questions, because for me it's a very sophisticated topic. I have to confess that I don't know many children with this problem. So maybe Dr. Kopyta has some questions.
Just out of curiosity, could you tell me what was the background? Why was the who made the decision, obviously an ophthalmologist, which procedure should be performed and what was the basis for this decision? Because definitely one of these procedures seems to be better than the other.
Yes, the background is this disease is very rare, and there are no studies yet about the effectiveness of this method of treatment. So, as I said before, the etiology of this of glaucoma with this in this Sturge-Weber syndrome is different than the conventional glaucoma. So the treatment methods effectiveness is different than it is in the standard in the standard treatment of glaucoma.
Thank you very much.
Thank
so
you.
They are just getting some experience.
Yes, I think so.
Thank you.
Thank you very much.
Thank you very much. And let's move on to the third presentation. And please welcome the next presenter of the presentation, whether APS FX technology will provide improved glycemic outcomes in comparison to the previous therapy.
Welcome, ladies and gentlemen, the committee members and my fellow colleagues. My name is Miłosz Tworek, and on the behalf of the Department of Pediatrics and Children Diabetology, I'm delighted to introduce our study, whether CAM-APS technology will provide improved glycemic outcomes in comparison to the previous therapy. At the end of my speech, there will be time for discussion, so I strongly encourage you to ask questions in order to dispel any doubts related to our project. So shall we begin? So the importance of achieving healthy glycemic control has been clear to prevent long-term type 1 diabetes complications has been clearly established by very well-known facts of evidence-based medicine. However, achieving these recommended glycemic targets, and especially in very young children, still remains challenging. And that's because of a number of factors, including the high variability in levels of insulin required, and of course, how individual children would respond to the treatment, and of course, their unpredictable eating and activity patterns. And
Sorry, because we have a little technology problem. We need to share your presentation first. I'm sorry, I'm very sorry. And yeah, no.
So there is no doubt that in recent years, there has been a significant increase in the incidence of type 1 diabetes. And this phenomenon has forced the search for newer and newer treatment options for diseases, such as insulin pumps and continuous glucose monitoring. And while these technologies have that shows that there's still considerable opportunity to not only improve glycemic controls, but also what is the most important, the quality of life for patients suffering from this autoimmune disease. And the current technology, sensor augmented pump therapy, it requires parents to review their child's blood glucose levels and to manually adjust the amount of insulin administered by the pump. And newly introduced in Poland, CAM-APS is a smartphone application to manage glucose levels in patients with type 1 diabetes. And this technology seems to be a promising tool in the treatment of this disorder, but will it improve the glycemic outcomes? Let's find out. So the aim of our study was to evaluate the difference in maintaining appropriate glycemic metrics in patients with type 1 diabetes in comparison to the previous sensor augmented pump therapy. So Professor Roman Hovorka from Institute of Metabolic Sciences at the University of Cambridge has developed the smartphone application called KAMA-PS, and which combined with glucose monitor and insulin pump acts as an artificial pancreas, automatically adjusting the insulin it delivers based on the predicted or real-time glucose levels. And it is a hybrid closed-loop system, which means nothing else than the child's carer will have to adjust the additional amount of insulin in the bolus before carbohydrate-containing snacks, but at all other times, the system works by itself. And the algorithm, which is the Android smartphone application, KAMA-PS, it directs insulin pump. The Dana is not currently available in Poland, but the IPSO pump. And it does it by giving the extended boluses of insulin, and it calculates the right insulin infusion by provided with the Dexcom G6 continuous glucose monitoring, which tells about the current glucose levels. And moving on to materials and methods. So our database from sensor augmented pumps included 14 days records of 14 patients with type 1 diabetes duration about 3.8 years, and were compared to the first 2 weeks of using KAMA-PS technology. And the records from a patient's history were collected from visits to the Department of Children Diabetology as well as from the software. And the condition was that only users with the sensor use value above 70% were included in the study. And the impact of initiating KAMA-PS was evaluated by comparing the outcomes we gained from the previous sensor augmented pump therapy to outcomes we reached after 2 weeks after KAMA-PS was enabled for the first time. And that brings me to the next point, which are results. And during 2 weeks of using KAMA-PS, patients have initially gained proper glycemic control. And starting with glucose management indicator, which what is this metric? It says what the A1C levels are likely to be based on the average continuous glucose monitoring data from past 10 to 14 days. And these numbers can help us determine what the A1C value would be. And after these 2 weeks of using KAMA-PS, the glucose management indicator value decreased from value 7.03 to 6.72. And moving on to sensor glucose average. So this parameter also decreased from value 155 to 142. When it comes to coefficient of variation and total daily insulin, so these metrics remain unchanged, so we treat it as a good result. And what is interesting that the time in range has increased from 65 to 75%. And the time in range is nothing else than a percentage of time the person spends with their blood glucose levels in a target range. So the increase in this parameter, after 2 weeks of using KAMA-PS, we consider as a promising change. So in conclusion, we can assume that after transition from previous sensor augmented pump therapy to KAMA-PS technology, patients have initially gained improved glycemic outcomes. And I strongly highlighted the word initially. It's because of the smaller group of patients, which we have because it's already introduced in Poland from January this year. And of course, from the only 14 days of our study. So thank you for your consideration. I really hope I've drawn your attention to our project because it's really important to be updated with newest options, as the diabetes is the disease we see in our everyday medical practice. And of course, according to our promising results, we've already extended our study, and we can see that even next weeks, their glucose levels are still getting better. And we are delighted that we can take part in finding new solutions for improvement of patients' life. So thank you again for your attention.
Thank you very much. And now let's move on to the discussion. Do we have any questions? Yes, please.
Is there a question or should I ask one?
Oh, you can ask.
Okay. From what I understood, this new technology sounds really promising. First, my question is whether the differences in the achievement of the goals in glycemia and the time in range, most of all, were they statistically significant, or the numbers you had were too small to calculate such a significance?
Yeah, the timer change was statistical, but the sensor glucose average, no.
Mm-hmm. And from what I understand, this is not covered by the state, this new technology. The patients have to buy it. Is that true, or am I wrong?
This technology? So,
yeah.
Yeah, actually the application Camapes, which is now only available on Android system, it costs about, the subscription for this application costs about 1,000 Polish zloty, and it's not refunded. But when it comes to other components of this hybrid closed loop system, so the Dexcom G6, which is this continuous glucose monitoring, is refunded. And also the IPSO pump is refunded from this year, the January, but without refundation, it costs about 10,000 Polish zloty.
So it depends on the refundation that you will gain more patients for your study, I understand, because as you mentioned, this is really a small group, but of course it sounds promising. Anything that makes life of these children easier, it's promising. But the always question is the money, because the parents will probably not be able to buy for every child such a new technology. I think you agree with me.
Yes, of course. But then we had only 14 patients, but now we have about 40 to 50 patients using this technology.
Okay. Yeah. So this is growing. Okay.
Yeah.
So I cross my fingers for the higher numbers of children in your previous study, and you will show us the results in the future.
I really hope that I can be the
Thank you.
pioneer. Thank you.
Thank you very much. And we have time for one more question, and we have a question from one of our participants. So let's ask a question.
During the study, have you noticed any fluctuations in effectiveness of treatment according to the age of patients, or was the effectiveness the same all throughout the age groups?
Actually, there was a difference. The older children gained better glycemic outcomes than the younger ones.
Thank you.
Thank you. Okay, thank you.
Thank you very much for all these questions, and please start the next presentation, cerebral mutism after resection of midline cerebellar or intraventricular posterior fossa tumors in children.
Hello, and thank you for the opportunity to present at this year's conference. I'd like to talk about cerebral mutism syndrome, which can occur after resection in the midline cerebral and intraventricular posterior fossa tumors, especially in children. Quick introduction: cerebral mutism syndrome, or CMS, is a type of speech impediment that can occur after surgery intervention within the posterior fossa, especially within the fourth ventricle. CMS in its nature is a temporary, a self-resolving condition, but it can have other initial additional additional symptoms like emotional liability, cognitive and motor abnormalities. The acute phase tends to resolve on its own, usually within 6 months. The occurrence rate of CMS is about 32% for PS intervention. For the etiology, currently we assume it's a disruption of the dental-thalamal cortical tract, which leads to a cerebrocerebellar dysthesis, which leads to an apraxia type of inhibition and an inability to talk. For risk factors currently known are large tumors above 5 centimeters in diameter, midline and brainstem location of the tumors, and associated tumors are medulloblastoma, which are the most often tumors associated with this complication. For treatment, currently there is no standard treatment specifically for CMS. As such, patients receive logopedic and neurological rehabilitation. Currently, there are some data to indicate pharmacological treatment using SSRIs or benzodiazepines. Within this benzodiazepines, we have midazolam, which we also published a paper of a case report of a patient who had an evaluation of their CMS syndromes after administration of midazolam. As such, the aim of our study was to determine the frequency, types of clinical manifestation, and risk factor for CMS in midline cerebral and interventricular posterior fossa intervention. Our study, we examined documentation from the years 2002, 2021 for patients that underwent a fourth ventricle and cerebral vermis tumor resection in the Department of Pediatric Neurosurgery in Katowice. We analyzed documentation, imaging studies, and did follow-up calls when necessary. For statistical analysis, we used statistical version 13.3. To assess the overall outcome for our patient, we used the modified ranking scale, which assigns points from 0 to 5. The fewer points, the better. Most deciding factor is the ability to walk assisted or unassisted. Our study population consisted of 156 patients, 86 boys, 70 girls, with a mean age of 8.1. Within that group, 13.46% displayed signs of CMS after surgical intervention. If we look at the preoperative symptoms, we have a grouping of nausea, vomiting, headaches, which indicates non-specific increased intracranial pressure, as well as impaired balance, impaired walking, ataxia, symptoms that indicate a cerebellar involvement. When it comes to location, our main inclusion criteria was a location within the fourth ventricle and vermis. As such, 85% of patients had tumor location inside the vermis, 26% fourth ventricle. Additionally, some of the tumor spread to nearby structures, such like the cerebral hemisphere, peduncle, cerebral pontine ankle, and brainstem. If we look at the prevalence of the tumors in our study group, splitting up into CMS population and total population, we see a confirmation in current literature that medulloblastoma is definitely the most represented with 52%. After that, we have astrocytoma with 23%, ependymomas with 15%. If we look at the prevalence of symptoms in the study population, we see the major grouping of indication of increased intracranial pressure, while compared to the overall population, our CMS population has an increase in symptoms that indicate cerebral involvement. Additionally, statistical analysis has shown that limb ataxia and truncal ataxia seem to have a meaningful correlation with the possibility of CMS occurrence. In our early follow-up, which happened on the day of discharge after initial surgery, which was average of 11.5 days, 13.5, 21% of patients had CMS. On the late follow-up, with the average time of 55 months, only 3.7% still have some persistent speech impairment, which represents about 1/3 of initial CMS cases. If we compare the groups, the CMS group on early and late follow-up in the MRS scale, overall, both in initial and late follow-up, the majority of patients had a positive outcome, with about 60% in the initial outcome having 1 and 2 points, and 70% in the late follow-up having between 0 and 2 points. In the initial follow-up, we had sadly 1 death. In the late follow-up, we had no patients that had more than 4 points. So in overall, it was a better outcome for the patients in the late follow-up. The literature given occurrence rate for CMS, as I said, is 30%. We had an occurrence rate of about 13%. We see a potential explanation in our surgical approach, which is the televelar approach. It's a type of suboccipitable craniotomy, after which we have a resection of the cerebral hemisphere and tonsils. This approach takes advantage of the natural tissue planes, leading to a way less traumatic approach and great access to the fourth ventricle for the operator. Additionally, our inclusion criteria for the fourth ventricle and vermis location was already a high-risk group for CMS, so our low occurrence rate is notable. In conclusion, it's possible that televalvular approach could explain our low recurrence rate. So if possible, it should be taken as the preferential surgical approach. We also need to raise awareness of CMS occurrence, because one of the reasons for our low recurrence rate could be a systemic underreporting. And the most important treatment takeaway is that we should raise awareness of CMS, because it leads to the crucial early start of orthopedic rehabilitation, which can give the best possible outcome for our patients. Thank you. And I invite questions.
Thank you very much. And now I would like to invite you all to ask questions and discuss the presented paper. Yes, we have one question.
Thank you for the very interesting presentation. I have a question. Is the logopedic care or logopedic rehabilitation, is it available in children after the surgical operation? Is it for free or?
It's not a standard procedure for now to give logopedic care to patients, but if the leading physician suspects CMS, of course, if it's possible, logopedic care is to have long-lasting speech impediments, most often mild dysarthria. They also have a higher risk of having development disorders. So it's also an additional risk group that simply we just want to take care of as quickly as possible.
I also have a question, because in the title of your presentation, there is the word of mutism. Do you mean a total inability to speak or just distorted speech? How would you?
Well, the name is appropriate. It's mutism. Usually it presents as mutism, so the inability to speak. It's in a type of apraxia. So the cerebral structures, the supratemporal cerebral structures responsible for speech are morphologically unchanged, but because there is a lack of coordination between cerebrum and cerebellar, we have a case of dysthesis, and simply the patient is incapable to for cerebral involved phonetic formation of speech. So it's the inability to speech, and later this translates to dysarthria when it resolves on its own.
What would be the longest time that you could be optimistic that these things will resolve? How long would you say you can wait? Can you just more or less?
The average is 6 months, and it almost always, the acute phase almost always resolves on its own. So, but as I said, the quicker we start rehabilitation, the lesser the long-lasting signs.
Okay, were there the cases where the symptoms never resolved and the children stayed mutic for a lifelong time?
Literature says that there are such cases in our study group, which was 156, which is quite larger than all the paper currently available on the subject. We didn't have any cases of permanent mutism, but as I said, about 3% of patients had long-lasting in the later follow-up, so 55 months after surgical intervention, they still had speech deficits.
Okay, thank you.
Great presentation, congratulations. My question is about midazolam. Did you use it, and when did you use it? And could you explain the action of midazolam in this entirety? Thank you.
We had
Okay, so it was sedation before MRI.
It's a case report of a patient who had like pre-MRI sedation, midazolam. A few minutes after administration, the patient starts speaking again, communicatively. Currently, because of the mechanism, cerebellum mutism is probably caused because, as I said, we have a dysthesis between cerebrum and cerebellum, which leads the regulatory impulses from the cerebellum no longer reach the supratemporal regions of the brain responsible for speech. But midazolam allowed for a downregulation, is the current theory that allowed to speech for momentarily to recover.
Thank you very much.
And it was a second proof of midazolam, because the first was, yes, the first one was in Italy. So we proved that they were not wrong. And we wanted to know everything about mutism, and I think it's background of this work.
Thank you very much.
Thank you for these questions. And now let's move on to another presentation, which will be held online. Please welcome Margarita Gerasimova with the presentation, Reasons for Vaccine Refusal in Pediatric Population in Latvia.
You see my screen, yeah? I see that. Cool.
Yes.
Good morning, dear jury members, colleagues, participants. My name is Margarita. I'm a 6-year student in Riga Stradiņš University at Latvia, and I would like to present you my pilot project research work about reasons for vaccine refusal in pediatric population in Latvia. And so starting with the World Health Organization in 2019 declared vaccine hesitancy as one of the top 10 biggest health threats in the world. To those unfamiliar with the term, vaccine hesitancy is a refusal or delayed acceptance of vaccines despite their availability and supporting evidence. Moreover, World Health Organization has recommended European region to provide at least 95% children immunization rate coverage. And according to Latvian Disease Control and Prevention Center in 2021, several vaccines did not reach this level. And as far as you can see on the screen, that's HPV, MMR, rotavirus, and chickenpox vaccines. So the purpose of the study is to investigate the most common reasons for the refusal of mandatory vaccination in Latvia and understand if general practitioner or pediatrician may influence parents' opinions regarding vaccination. Speaking about the materials and methods, then research data was collected in two ways: primary data by telephone interviews with the child provider, and secondary data from children's medical documentation in GPs or pediatrician practices. So in random manner, around 1,000 children medical documentation were seen, and out of those people, around 171 children were included in the study. Inclusion criteria were children until the age of 15 years who don't have one or more vaccines, or written refusal in medical documentation were obtained, and they also needed to be the Latvian citizens. Out of 128 children providers, only 69 agreed to participate in telephone survey. Data were obtained on the vaccination status of children, vaccines received, did not, reasons for refusal, and can GP or pediatrician influence parents' views, etc. Data were analyzed using mainly descriptive statistical methods, and that study is approved by ethics committee. And moving on to the results, I want to stress here that when I analyze data, I counted only vaccine doses received. It means that if a child received 2 pneumococcal doses, it was just like first dose of pneumococcal vaccine and second. I was not counting the administration time, so it's not included in my research. So instead, the 15 zero-dose children were registered. Those are the kids who did not receive any of the vaccine. However, potentially this number could be higher, because if you take a look on the right table, you can see that the highest vaccination rates are for tuberculosis vaccine, which is 87.1%. And in Latvia, you receive this vaccine within 24 hours in a hospital, and some parents are actually stressed out that they didn't have a choice to refuse the vaccine. Luckily, also the high numbers of vaccination are for diphtheria, tetanus, and pertussis vaccine as a part of 4 or 6 component vaccine. That's almost 82%. And unfortunately, the lower rates are for pneumococcal vaccine. 76.2% of kids did not receive any vaccine doses. For chickenpox vaccine, no one received 88.5%. And also pretty high numbers are for HPV vaccine. Out of 35 kids, only 3 received this vaccine, which matches with the statistics previously mentioned. Moving on to the reasons for vaccine refusal, then the main reasons for refusal, as you can see also in the chart, are fear of side effects. That's 23 times parents said disbelief in new vaccines, vaccine formulation, and the safety of vaccines overall. 17 times parents stressed that children can get sick and will recover from disease by themselves. What was interesting that 11 parents said that they never refused vaccine. However, in a study were included only kids who did not receive at least one vaccine, which is pretty important. That was quite also interesting that 9 parents refused vaccination because of insufficient knowledge, and over time those 9 parents were the ones who decided to vaccinate the kid. And also, it was interesting for me, 2 parents lived all natural lifestyle, and what was first hearing for me, but I hope not for professors, that patients, one mother did homeopathic vaccines, which are not obviously proven. Also, using Fisher's test, statistically significant association has been found, at least in my research, that parents with secondary professional education more often refused all vaccines. And speaking about parents' opinion on vaccination and can be it influenced by general practitioner or pediatrician, 45 out of 69 parents said that consultation with the child's doctor can influence their opinion, and less often informative materials, for instance, our clinical research, a hospital, for instance, made materials can influence their views. So in conclusion, I want to say that the most common reasons for vaccine refusal in Latvia are fear of side effects, vaccine safety aspects, belief that children can catch the disease and recover from it acquiring natural immunity, and medical professions and medical specialists provided informative material also can influence respondents' opinions on the need of immunization. So thank you for your attention.
Thank you very much for this presentation. This is a very interesting topic. So do we have any questions?
I have a question, because you said that there's an influence of the doctors, but you mean the positive influence or the negative influence? Because I noticed there is one response that the doctor said they should better not vaccinate the child, but that was only, I think, one case or 1%. I didn't really understand. Can you explain that?
That's one time when the person said that was actually some professor said to mom that they should not vaccinate children against B hepatitis virus. So that was the case, but that was not the general practitioner and pediatrician where I did my research.
Mm-hmm.
Yes, and talking about the influence, yes, I was talking mainly about the positive influence, that there were two questions, like one question asked, and the answer possibilities were most likely will influence, parents will vaccinate their kids or will not. Yeah.
Okay.
So
mm-hmm. Thank you. Now I understand it.
Thank you. Maybe someone from our participants or on-site jury has any question?
Yeah, anyway, I think this is a very interesting study. You know, we have the same results will probably appear if we make infection, so that there were some strong protests against vaccines. But I don't really know how you can influence these people. They probably are not resistant to any influence.
Actually, when I was doing the study, what was really interesting were there were parents who were like strictly against the vaccination. Doesn't matter what you do, it will not change their mind. Right. However, in my research, around 20% of parents during some time when their children grow, they change their mind and decided to vaccinate. And that was mainly due to the doctors who spoken with moms and said, for instance, let's do the DTP vaccine for first one, for instance, and then they just like, oh, maybe MMR and maybe something else and maybe HPV. So yeah, and that changed their mind actually.
So a little bit of optimism then.
Yeah, hopefully.
Thank you very much for the discussion. And now let's move on to another presentation, and I see our presenter is ready. So please welcome another participants. Read first Verescuns, gender, ILRR subtype, and immunogenic findings as risk factors for uveitis in JAA patients in Latvia.
Yes, thank you very much. Hello, dear colleagues and esteemed judges. I'm also a sixth-year student in Riga University, and today my topic is gender, ILAR subtype, and immunogenic findings as risk factors for uveitis and juvenile idiopathic arthritis in Latvian pediatric population. I'm sorry. Juvenile idiopathic arthritis is the most common rheumatic disease in pediatric population, which affects approximately 1 in every 1,000 children. It is defined as an arthritis with duration of at least 6 weeks in a child under 16 years of age without any other known cause. And nowadays it is commonly divided into 7 subtypes according to International League of Associations for Rheumatology classification, which are as follows: oligoarthritis, seropositive and seronegative polyarthritis, systemic arthritis or Still's disease, antiseeds-related arthritis, psoriatic arthritis, and undifferentiated arthritis. And the uveitis is its most common extra-articular complication, and it can be asymptomatic, or it can also lead to severe vision impairment or even blindness. And various literature sources place the prevalence of uveitis anywhere between 5 to 25% of juvenile idiopathic arthritis patients. And this large discrepancy can be attributed to multiple factors, such as, for example, geographic location. And it is the prevalence is higher in Northern Europe. And there are certain factors which are apparent early at the juvenile idiopathic arthritis diagnosis, which can indicate an increased risk of developing uveitis in these patients. And these factors are female gender, oligoarticular subtype, and antinuclear antibody positivity. And in addition, some literature sources also suggest HLA-27 as a more minor risk factor for uveitis. And as such, the aim of this study is to evaluate gender, ILRR subtype, and immunogenic findings as early indicators of increased risk in Latvian juvenile idiopathic arthritis patients. The study was performed by gathering data from patient histories that were available in online database of Children's Clinical University Hospital here in Riga. And the study included all patients that were hospitalized at least once to receive treatment for juvenile idiopathic arthritis in the last 5 years. And recorded information included the presence of uveitis, as well as patient's gender, the arthritis subtype, as well as presence of rheumatic factor, anticyclic citrullinated peptide, and already mentioned DNA and HLA-27. And so, as a result, a total of 546 patients were included in the study, and out of them, 5.1% were diagnosed with uveitis. And as you can see in these graphs over here, if we compare gender distribution in the uveitis patient group, it is similar to the gender distribution within the whole observed patient group. And indeed, using a chi-square test, there was no statistically significant relation found between uveitis and gender. And in this graph here, you can see that more than half of uveitis patients were suffering from oligoarthritis, and a bit less than half were suffering from seronegative polyarthritis. And using Fisher's test, there actually was statistically significant relation found between uveitis and ILAR subtype. In particular, it was found that oligoarthritis patients were statistically significantly more likely to develop uveitis. And here you can see the immunogenic findings. If you look at the uveitis patient group, we can see that in this group, there were no seropositive patients. And in addition to that, most patients in this group were HLA-27 negative. However, almost 3/4 of these patients were ANA positive. And unfortunately, in none of these patients in the study had anti-CCP antibody analysis done, because this is a bit more rarely performed test. And using statistical analysis, there was no statistically significant relations found between uveitis and these findings. And in conclusion, comparing the amount of uveitis patients in our study with international data, it was substantially lower than in North and South Europe, but it was more closely more closely resembled the findings in Middle East and Southeast Asia. And there were statistically significant connections found only between ILAR subtype and uveitis, meaning, as I already said, oligoarthritis patients were more likely to develop uveitis. And literature sources show that oligoarthritis is the most common juvenile idiopathic arthritis subtype overall, as well as the most common to develop uveitis. And in this study, as I mentioned, it was the most common among uveitis patients. However, amongst the whole patient group, it was the second most common. And even though most uveitis patients were indeed girls, their proportion in the uveitis patient group was actually smaller than in the whole patient group. But these findings were still within the still similar to the findings in literature that were found in the Western world. The literature also suggests that the most consistent predictor of uveitis development in juvenile idiopathic arthritis patients is, in fact, the presence of ANA antibodies. However, in our study, even though there were more ANA positive patients in the uveitis group, there was no statistically significant connection found between the uveitis and ANA comparing to the whole patient group. And a recent study conducted in Northern Europe actually had similar results. There was no statistically significant differences in gender or ANA positivity among the patients with or without uveitis. And contrary to literature, in this study, the amount of HLA-27 positive individuals was actually higher in the group of patients without uveitis. And in the end, there were actually some literature sources that suggested that seropositivity is actually associated with relatively lower uveitis risk. And indeed, in our study, there were no seropositive patients with uveitis. So thank you for your attention. I'm open to your questions.
Thank you very much for another interesting topic. And I would like to ask the question about the paper. So maybe first I ask about your own contribution to this work.
Yes, thank you for the question. Well, I did the whole work. I gathered the information, and we used statistical analysis methods to draw the conclusions, and it was approved by my work tutor.
Thank you.
May I ask you the question, because in your title of your presentation is arthritis in Latvian pediatric population, but then you did the comparison between other countries in Europe. Did I understand it right? So you made a meta-analysis of the literature, or can you explain that? Maybe I didn't catch the point.
Yes, thank you for the question. Yes, well, I gathered all my information, and as I mentioned, Children's Clinical University Hospital in Riga, which is the main children's hospital in Latvia. So we could, from this one hospital, we could gather sufficient info that would represent the whole country. And I felt that it was necessary for this work to also compare my findings with international data, and in particular with data from Northern and Eastern Europe, so with this geographical region, as maybe there are some significant geographic differences between my findings and between the similar findings in other countries in this region. I hope I answered.
Well, what was your question based on? That the position, geographical position is different, or the symptoms are different? You know, just give me the idea. Why did you do that? What would you expect?
Well, I would expect that my findings would be first similar to like the overall literature and like overall literature that suggests clinical praxis, because these findings that I looked at, the gender, the arthritis subtype, and immunogenic findings, they are suggested to in clinical literature, like in the whole world. And so I thought at first they would be like my findings should be similar to like the whole world literature about the whole world, and also that like more particular findings such as the percentage of affected, well, for example, girls, as I mentioned, like the gender distribution, that would be similar to this more local geographic distribution. But indeed, as you saw in the work, there were like, even though these findings were similar, they were the statistically significant connections were only between the subtype and uveitis risk. So we can gather from this particular work that there were significant like differences, like, and they could be related to geography, could be related to multiple other factors that are beyond the scope of this research work.
Yeah, but because your population is mostly Caucasian population.
Of course, yes.
Okay, thank you very much.
Thank you for this question, and we're out of time for our discussion. So thank you very much. And now let's move to another presentation. Please welcome Alexandra Skobir with the presentation Antenatal Corticosteroid Treatment of ELBW, VLBW Infants, a multicenter study in Podkarpacki province. So, I'm sorry, we cannot hear you. Please write us if you use the application or
It seems you have a connection problem. Maybe we'll come to another presentation and then come back to this one. What would you suggest?
I think we need to move to another presentation, and please check if your internet connection is right, or do you have settings with the microphone so we can hear you, and we will ask you at the very end to present again. So now let's move to another presentation. Biological therapy in children with IBD single center study.
Welcome, ladies and gentlemen. My name is Julia Osińska, and I'm honored to present to you our study titled Biological Therapy in Children with IBD, Single Center Study. Let me begin with some background information. Inflammatory bowel disease is a group of chronic inflammatory disorders that consist of Crohn's disease and ulcerative colitis. Their prevalence is rising in pediatrics populations. When other treatments fail to be effective, biological treatment creates possibilities to induce clinical remission and prevent the appearance of complications of such diseases. Biological drugs that are registered in Poland for IBD in children are mostly anti-TNFs, which are infliximab and adalimumab, followed by other groups of drugs, such as anti-integrins and those that are still in making. The aim of our study was to evaluate the indications, effectiveness, and complications of the biological therapy among pediatrics patients with IBD. When it comes to method and materials, we observed children with the diagnosis of IBD that were qualified for biological treatment, hospitalized at the Department of Pediatrics in Katowice, Medical University of Silesia from 2010 to 2023. As per this slide, we can see what data was taken into consideration, and the data was statistically analyzed. Our study group consisted of 75 patients aged from 4 to 17.5 years old at the time of diagnosis, with the mean age being 12. 48% were female and 52 were male. 41 patients suffered from Crohn's disease, whilst 34 from ulcerative colitis. Now let's look at the localizations of the lesions found on endoscopic examinations. Majority of the lesions found among patients with Crohn's disease located in colon, followed by those found in the distant 1/3 part of ileum, ending with those of ileocolonic distribution. When it comes to patients with ulcerative colitis, lesions predominated on the left-sided colon, followed by extensive colitis. The median age of patients at the time of the introduction of the biological therapy was 15 years, and the median time from the diagnosis of the disease to the initiations of BT was 12 months. No statistically significant differences were found between patients with Crohn's disease and ulcerative colitis. Now let's look at the indications for the biological therapy. The most common reason were severe exacerbations, present in 80% of our cases, mostly due to steroid dependence and less steroid resistance. In 5 patients, BT was used as a rescue therapy due to their exacerbating condition. Moreover, among patients with Crohn's disease, 13 were qualified for biological therapy because of perianal fistulas. The most common drug used among our patients was infliximab, present in 71 cases, followed by adalimumab, vedolizumab, and ustekinumab. 12 patients underwent and then 9 followed on adalimumab and 3 on vedolizumab. 2 patients underwent therapy. Then adalimumab, 1 patient followed on vedolizumab and the other one on ustekinumab. Now let's turn our attention to the effectiveness of the biological therapy. We assess the effectiveness of BT based on the changes in the PCDAI score and PUCAI score for Crohn's disease and ulcerative colitis, respectively. The median PCDAI score before treatment was 55, and it decreased to 10 after completing all the cycles, which can be noted as 61.9% effectiveness. When it comes to the median PUCAI score before treatment, it was 55, and it also decreased to 7.5, which can be noted as 75% effectiveness. Both differences were statistically significant. Now let's look at the nutritional status of our patients. In majority of the cases, we have found no changes in the BMI status. However, in almost 1/3 of our patients, the BMI increased after biological therapy. Turning our attention to the complications that occurred in 31 children, with the most common one being anaphylactic reaction. Anaphylactic reactions mostly happened during infliximab therapy. Only 1 patient experienced therapy. A majority of the anaphylactic reactions happened on the 2nd cycle after 2nd dose. Let's look at some other complications now. In 8 cases, there were abnormal laboratory findings, such as leukopenia and neutropenia, elevated liver enzymes, and high triglycerides. Other groups of complications included neurological ones, such as headache, dyscalculia, encephalopathy, and hand tremors. 4 patients experienced infections as a complications of BT, such as EB your attention. I would like to invite my colleagues now for the discussion.
Thank you very much for the interesting topic. And now I would like to ask you to join the discussion. Yes, our participant has a question.
Yeah, I would like to ask you, what was the main reason of the death of this patient? That was the anaphylactic reaction that you couldn't take care of, or was it? Appreciate the statistical work you have done. I think that was really something impressive. So I was really, I learned a lot from from your presentation, because this is not the topic of my work. So I can just congratulate you on that.
Thank you very much.
Have you seen any significant improvement in quality of life in your patients that have been treated with biological therapy?
Yes, of course. For instance, on the slide of the effectiveness of the biological therapy, we have seen the decrease of the score of the PCDAI and PUCAI. And those scores include symptoms such as abdominal pains or the loss of consistency of their stools. And as though this score has dropped, also did the symptoms.
Okay. Thank you for the nice presentation. We like the biologic therapy, and we know that we have a lot of side effects. Could you tell more information about this encephalopathy? Because I am very interested. What was the clinical picture of the encephalopathy?
So the first symptom of this case with encephalopathy was that this patient couldn't lift his lower limb. The mother contacted the doctors that said that they should immediately come to the hospital. At the time when they came to the hospital, this patient couldn't walk. Then he lost the mobility in these upper limbs, then sensory distractions, and followed on the respiratory muscles paralysis.
What age was this child?
He was, I think, 6 years old.
Okay. And under therapy of infliximab or adalimumab, do you know?
It was infliximab.
Infliximab. And the second question, what is the access to the vedolizumab or ustekinumab therapy in Polish children? You know, is it available or not?
It is available, however, in very few cases, because this therapy is mostly used as a rescue therapy, and a special petition has to be drawn to get access to such drugs.
Yeah, it's true.
Lovely presentation. Thank you very much. I'm just wondering if you have compared the side effects you have observed in your study with the side effects which are reported by other researchers around the world. Is it similar?
Okay, so it should be emphasized that the serious side effects of biological therapy in children, the data are very limited. Especially when it comes to neurological complication. It is estimated that it occurs in approximately 3% of patients. However, it is most based on the study, which include adult patients. So, as we said, the encephalopathy is quite serious condition, and we don't know the incidence of this condition among the patient treated in biological therapy. But another important complication are anaphylactic reactions. So in one of the bigger study, the anaphylactic reaction occur in approximately 15% of pediatric patient. And compared to this result with our data, in our study group, the anaphylactic reaction was in approximately 24% of cases. So we in our study, this percent is higher than compared to another study. And of course, another complication is infectious. And in our study, the level of the percent of patient with infectious was lower compared to another study. However, we were taking into consideration severe infections, and not the whole group of the infection that may occur in every child, like not only in the biological therapy.
Thank you very much. You should absolutely publish the results. Thank you.
Thank you for all this question. Unfortunately, we're out of time for this discussion. So please, thank you very much. Please welcome another presenter with the paper Characteristic of Rotavirus Infections in the region of Silesia between June 2019 and August 2022 in terms of mandatory vaccination.
Thank you. Can I have this, the change slides? Okay, thanks. Okay, hello everyone. I'm Veronika Ressler, and I'm honored to present our work, Characteristic of Rotavirus Infections in the region of Silesia between June 2019 and August 2022 in terms of mandatory vaccination. My presentation contains introduction, aims and methods, study group results, and conclusions. First of all, I would like to briefly introduce you to the topic. Because rotaviruses are the leading cause of acute gastroenteritis, AGE, in the children under the age of 5. AGE is characterized by the rapid onset of typical symptoms, such as nausea, diarrhea, vomiting, abdominal pain, with or without fever. In Poland, since 2006, rotavirus vaccine has been available, but it was accessible only chargeably and voluntarily. So it was included in the 2021 National Immunization Program. And another thing is that due to SARS-CoV-2 pandemic in the spring and fall of 2020, pandemic restrictions have been introduced in Poland, such as social distancing, hand washing, temporary closing of nurseries, kindergartens, and school. And because of these two factors, we decided to conduct a study that aims at the impact of mandatory vaccination and pandemic restriction on the morbidity and severity on the rotavirus-induced AGE in the children hospitalized at the Department of Pediatrics of Medical University of Silesia in Katowice, Poland. So our group consisted of 324 patients that were hospitalized in our department, and all of these patients had RV infection that was confirmed with laboratory results. And after gathering of the medical information, we did the statistic. And our analysis included age, sex, hospitalization time, clinical symptoms, hospitalization month, pandemic restrictions, and laboratory results. Our group covered 324 patients, and 46% of them were under the age of 2. The rest of them was between 2 and 14.5 years old, and 56% of them were male. And about clinical symptoms, 95% of them had diarrhea, more than 80% of them had nausea and vomiting, and 75% of them had fever. And now going on to the laboratory tests, what is noticeable is that more than 70% of our patients had abnormal AST levels. Also, what is really important is that more than half of our patients had abnormal BE levels. And now moving on to the results, after collecting this medical data, our analysis revealed that after introduction of mandatory vaccinations, hospitalization age of children was significantly higher. it was 3 years, 7 months, compared to 1 year, 7 months before introduction of this vaccination. So it's a really big difference. Also, hospitalization time was significantly lower compared to the time before introduction of this vaccination. As you can see, after the vaccination, this time of hospitalization was around 5 days, and before this immunization, the time of hospitalization was 6.42 days. And we gathered the information in the table that is visible there, so you can observe the differences between the periods before and after introduction of mandatory vaccination, considering the admission age and the hospitalization time. Also, we analyzed if the children were attending educational institutions. As you can see, overall, more hospitalized children did not attend educational institutions. However, more than 70% of them had older siblings that were attending these institutions. That means they could have had this infection from the sibling that was going to educational institutions. And interestingly, by dividing the groups by the types of facility, more of the hospitalized youngest children did not attend the nursery, but the opposite correlation was observed in the case of kindergartens, where significantly more hospitalized preschool children attended kindergartens. And as you can see on this diagram, no seasonality was visible for the periods 2019-2020 and 2020-2021. However, in the periods 2021-2022, the seasonality is definitely visible. And the number of cases between December 2021 and March 2022 was 47 times higher than in the period December 2019 and March 2022, and 7 times higher in the period June 2020, November 2021. And also, we analyzed the influence of mandatory restrictions during lockdown and other pandemic restrictions, such as social distancing, widespread hand sanitizing, masks. The number of patients was significantly lower compared to the periods before these restrictions and after these restrictions were removed completely. And that brings me to the end of our presentation. So we observed positive effect of compulsory vaccinations on the morbidity in the affected group and the overall hospitalization length. Also, we observed positive impact of pandemic restrictions on the number of RV infections. And of course, more research is needed to evaluate the efficiency of vaccine. Thank you for your attention. And do you have any questions?
Thank you very much.
And I also introduce my colleagues that are co-authors of our work.
Yes, and now let's move to the discussion.
Well, this is a very interesting work done. Well, you would expect such a results during the time of the lockdown. The people probably were more careful about the restrictions. And also, there may be another fact then that the people did not go to the hospital so often because there was a general belief that if you go to hospital, you will catch COVID. And so this aspect could be also taken into consideration. So maybe where the symptoms were not severe, the children would not also appear to the hospital. But of course, the influence of the vaccination is obvious. So I hope this will keep on going.
Yes, of course. Yes, we hope that we want to extend this study and gather information about patients from this year to check if this trend in lower number of cases after the introduction of compulsory vaccination is visible.
And it also seems that in the nursery, there is less infections than in the kindergarten. Would you agree with me, or did I understand it wrong? That in smaller children, there were less infection. That was because they were not attending the social care. I mean, they did not go to the kindergarten, or because they just stayed at home?
That is true, but after the introduction of mandatory vaccinations, we saw that the mean age of children was around 3.5 years old. So we had like more of kindergarten children, and it is because most of the children didn't get the vaccine.
Oh, okay.
So after this vaccination, we had more of the kindergarten children that weren't vaccinated.
Okay, thank you for explanation.
Thank you.
Okay, I have one question.
Yeah.
Congratulations for this very interesting lectures. In our department, we have a similar observation in upper respiratory tract infections. But I have one question.
Yeah.
Do you know, after the end of this pandemic period, number of complications such as rotavirus or no?
No, we had like after end of pandemic, we had a little bit more than usual number of a little bit more cases, but we didn't observe any other complications.
Okay, thank you.
Thank you.
Thank you very much. And with this question, we're out of the time. So thank you very much.
Thank you.
And please welcome the next presentation, next presenter with a presentation comparison between the quality of life of children with congenital adrenal hyperplasia and healthy ones.
Good morning, esteemed jury. Good morning, dear participants. Today I'm going to present you our study titled "Comparison between the quality of life of children with congenital adrenal hyperplasia and healthy ones." Okay, first of all, I want to briefly explain what congenital adrenal hyperplasia is. CAH is a rare genetic disorder caused by impaired steroidogenesis in the adrenal glands. The most common cause of this disease is lack of the enzyme known as 21-hydroxylase, but there are also other much rarer causes of this disease. CAH can occur in different forms, classic, which can be divided into salt wasting and simply virilizing, and non-classic. At the beginning, I want to say what could impact the quality of life of children diagnosed with CAH. First of all, children are required to take dosage of hydrocortisone 3 times a day and sometimes fludrocortisone on fixed hour, which can lead to skipping doses and low of compliance. And moreover, the doses changes as children grow, and it's sometimes hard to adjust. We should also remember about the hormonal imbalance connected with this illness. Too high doses of steroids can lead to Cushingoid features, delayed bone age, and delayed puberty. And on the other hand, too low doses of steroids can lead to precocious puberty and advanced bone age. Moreover, children with CAH require frequent endocrinologist appointments. And finally, 7 out of 11 children from our research group underwent the reconstructive genitoplasty surgery. And I want to briefly explain what our aim of study is. We wanted to answer those 3 questions. Does the quality of life of children with CAH differ from that of healthy ones? How does the disorder and its treatment impact children's quality of life? And does the perception of the impact of the disorder varies between children and their parents? We carried out our questionnaire using the pediatric quality of life questionnaire, adjusted to parents and children, and also adjusted to particular age groups. And in the next step, we compared the scores from children from our research group to their parents, and also to control group. Our research group consists of 11 children, 7 girls and 4 boys. 10 with classic congenital adrenal hyperplasia and 1 with non-classic, with mean age 12.91. And our control group consists of also 11 children, 4 boys and 7 girls, without any chronic condition. With mean age similar to our research group, 12.27. And now we can see the comparison of PET-SQL scores for CAH for children with CAH and control group. These are the scores, summary scores both for children and their parents. And the scores are statistically insignificant. And I want to briefly explain that physical health summary score presents the physical health dimension of functioning, and the psychosocial health summary score represents the social, school, and emotional dimension of functioning. Now we can see the comparison of PET-SQL scores for children with CAH and their parents, and also those scores are statistically insignificant. But when we divide the total score into particular dimensions, we can see that in parents' evaluation, children with CAH were scored lower in emotional dimension of functioning than healthy children. And also in parents' evaluation, children with CAH were scored lower in physical dimension of functioning. Moreover, there is one difference between the children from our research group and their parents. Parents evaluated their children's emotional functioning lower than children did themselves. And finally, there were no other significant differences between our research and control groups. And we haven't found any correlation between the quality of life and hydrocortisone dosage or BMI score. To sum up, children with congenital adrenal hyperplasia have similar quality of life to healthy children without any chronic condition. However, there is difference in perception of impact of the disorder between children and their parents. Parents evaluated their children's emotional and physical health lower than children did themselves. And it's really important to take both perspectives into consideration and focus on lower scored areas on functioning. And in the future, we are going to develop our study by expanding the research and control group. Thank you for your attention, and I will invite my co-authors to answer to your questions.
Thank you very much for this paper. Do we have any questions?
Yeah, I have one question. Congratulations for this lecture. It is very interesting are the results of this quality of life questionnaire. But could you tell me what is the prevalence of this disease and what are the typical symptoms of this disease? Because I am an otolaryngologist, that's why my knowledge about this is not so high.
So this is quite a rare disease, and the birth rate is about 1 per 12,000. And the symptoms really varies between the form of this disease, if it's classic or non-classic, and also from the sex of the patient, because usually boys have less noticeable symptoms of the disease, but but girls, when they are in the period of their puberty, we can see that they have like virilization symptoms. For example, they can have like deeper voice and too much hair on their body. But when we also want to discuss about the most hard and the most life-threatening form of this disease, like salt wasting, both girls and boys can have symptoms. The symptoms are connected with the aldosterone and the lack of aldosterone and also cortisol. And for example, children with this form of disease can have like hypotension or water wasting, and it can be some vomiting, and it can be sometimes life-threatening for them.
Any other questions?
Yeah, okay, but could you explain me what you think? Why is no differences between this control group and this examination group? Could you try, of course?
We are thinking about this, but in lots of research for this topic, that like the results were almost the same for research and for the control group. But I think that children are sometimes really they got used to this illness, so they don't like notice the symptoms in everyday basis. But parents, I think, are like more concerned about the health of their children. But children themselves, like I think they don't see this in basis life.
Okay, thank you.
May I say something about you? I think the problem of your research is the small number of children, and also that you put into one group the girls and the boys, because I'm sure you agree with me that undergoing a surgery of your genital organs, it's very humiliating for the girls. And I hardly believe they could not be concerned about that, and they have the same quality of life, you know, because yes, sometimes it's really humiliating for them, just even to go to the urologist, to gynecologist, and also taking the drugs 3 or 4 times a day, it's really a problem. So I think if you consider a higher group of children and you would compare boys to girls, then you will have different results. I'm pretty sure of that. And of course, it's a rare disease, but for the endocrinologists, which I am, it's not so rare. And I really see the high percentage of problems and the low quality of life of these children. So I would recommend that you just include more children in that in your study.
Yes, we are going to do this because we have like our research group from only one clinic. And also we have to get agreement from the children and their parents, and that's sometimes not really easy for them to like sacrifice some time for us, or to send us the questionnaire, but we are searching for the base in hospital, and like we are, I think, in a close future going to expand our research group.
Well, if you wish, you can include my patients. Would we be allowed about 20-25? So you may have a much higher group then.
Okay, thank you.
Can I ask, thank you for the nice presentation. Is this PETS questionnaire, is it easy available? Can every pediatrician use this questionnaire? Is it for free, or you should pay for it?
I acquired this questionnaire from a website,
okay,
and I emailed that company. It's available for free for non-profitable researchers, and only a generic scale is available for students. There is other variation of PET-QL scale for a lot of other diseases, but generic scale is only available for students, but it's more.
Okay, thank you.
Thank you very much for the discussion, and thank you very much for the presentation. And now, please welcome the next presenter. With the presentation, Synovitis complication in different stages of its development among pediatric patients.
Greetings, I'm Jan Ramian, and I wish to introduce you to our work, Sinusitis Complications in Different Stages of its Development Among Pediatric Patients. So, without further ado, let us begin. Sinusitis, also known as rhinosinusitis, is the most common condition in the pediatric population, and about 3% of the cases will lead to virus complications. And this will change depending on patient's age, which is a result of the gradual development of the sinuses, because at birth, only ethmoid sinuses are present, and later, as the patient ages, the maxillary, sphenoid, and frontal sinuses will gradually develop, and this process will take to around 20 years. As for the diagnosis of rhinosinusitis, we need to observe at least 2 from the 4 following symptoms. The nasal congestion, the mucopurulent nasal discharge, headache in sinus region, and cough, especially at night. As for the complications themselves, they are most likely arose from the acute sinusitis, rarely from the worsening of the chronic, and they are localized mainly in orbit and the brain because the infection spreads directly to them. It is important to know that the complications can occur despite appropriate treatment and antibiotic therapy, despite the fact that only about 2% of the inflammation is bacterial. Complications are divided into 3 main groups. The most common orbital, followed by intracranial, and the least common osseous. The aim of our study was to analyze the patients treated for the sinusitis complications and characterizes this group with an age breakdown. We had 63 patients that were treated for the sinusitis complications in our clinic, and we have gathered their medical data regarding the type of diagnosis, the interview and the physical examination, as well as the previous and implemented treatment with laboratory tests and imaging. We used the Fisher's correlation chi-square test to show differences in the indices of symptoms and complications. And our study group was, as stated before, 63 patients, 82% of which were male, and their average age was 8 years old. And we divided them into the groups with the criteria of average age, the 39 children below 8 years old, and the 24 above. As for the outcomes, 82% of the complications arose from the acute rhinosinusitis. And as for the symptoms, the most common were fever, followed by headache and runny nose. Overall, the most common complications were eyelid swelling, which occur in 58.7% of the cases, predominantly on the left side, followed by the orbital soft tissue inflammation in 12.7% of the cases, and other complications were about 5% each. And 40% of the patients reported previous antibiotic therapy, and there was also 2 cases of prior functional endoscopic sinus surgery. As for observed complications, we have found out two statistically significant differences in our populations group. The eyelids oedema was more prominent in the younger children group, while the combined intracranial complications were more common among older children population of our study. Other complications like orbital soft tissue inflammation were statistically insignificant. As from the treatment of these complications, the orbital treatment is different depending if it's a preseptal or retroseptal complication. And orbital septum is a layer of connective tissue localized under the orbitulus oculi muscle that divides the orbit into anterior and posterior part. And under Chandran's classifications, only eyelids oedema is preseptal complication. And these complications are treated with intravenous antibiotic therapy, anemizations of the mucosa, and rising of the nasal cavity with sea salt. However, if there is no improvement after 48 hours, or the symptoms are radically increasing, the treatment is as in retroseptal complications. And this concludes abscess drainage and functional endoscopic sinus surgery. For intracranial complications, we use also FES and the drainage of the abscesses, as well as intracranial intravenous antibiotic therapy. It is important to know that 9 of our patients were discharged on transfer to other departments for further treatment for problems like the ocular nerve inflammation, the unimpaired vision. So to summarize everything up, the patients over 8 years of age are more likely to develop intracranial complications requiring advanced treatment. The patients under 8 years of age are more likely to develop eyelids oedema, which is treated symptomatically, and complications may occur despite previous antibiotic therapy. Thank you very much. Now I would gladly answer your questions.
Thank you very much for this presentation. Does anyone have any question? Maybe someone from our online jury has any question? So first, I will ask you for your own contribution to this work. Please explain it to us.
My own contribution was I collected the majority of the patient's data, and I do all the statistical analysis of this work.
Thank you very much. Do we have any questions about the presentation? Okay, so thank you very much for your presentation, and please move on to another presenter. Okay, so the comparison of cortisol and 17-hydroprogesterone concentration in blood and saliva. Please welcome.
So good morning. My name is Magdalena Kwiatkowska, and I have pleasure to present our original research, which is called Comparison of Cortisol and 17-hydroxyprogesterone concentration in blood and saliva. Due to the hormonal variability throughout the day, it is important to use a diagnostic method that assesses the secretion rhythmic of cortisol and 17-hydroxyprogesterone. This helps avoid frequent blood tests and the associated risk. Therefore, alternative testing options are being explored to minimize complications for patients. Saliva collection is simple, non-invasive, painless for children, and doesn't require hospitalization or qualified personnel. Saliva is easily available biological material too. What's interesting, saliva samples containing hormones exist in an bound form, unlikely in the blood where they are mostly bound to proteins. So the aim of our study was to assess of the correlation between cortisol and 7-hydroxyprogesterone measurements using radioimmunoassays-based method in saliva and standard cortisol measurements using blood. Moving on now to our study group. Finally, a total of 122 patients hospitalized for planned HbA-axis diagnostics were included in the study. This was a prospective cohort group. The inclusion criteria were female gender, providing written consent to participate in the study, and it should be patients admitted for planned diagnostic HbA-axis. The concentration of cortisone 7-hydroxyprogesterone were determined using RIA methods collected twice from each patient at 8 a.m. The chemiluminescence method was used to measure the concentration of cortisone 7-hydroxyprogesterone in the blood. The measurement of concentration of cortisol were measured twice a day. 7-hydroxyprogesterone were measured at 8 in the morning. Additionally, to measure stereometabolism in 24-hour urine collection was performed on the day preceding the collection of saliva and blood samples. Then the steroid metabolism urine was determined using the SIMC method. All statistical analyses were conducted using statistical software. The results were considered statistically significant with a p-value lower than 0.05. So now look at our results. As we can see, a comparative analysis of ROC results from cortisol measurement in blood and saliva showed that saliva cortisol test is more effective in assessing steroid profiles with around the curve of 0.84 to 0.54. At the proposed cutoff points, the salivary cortisol test had higher sensitivity and specificity compared to the blood cortisol test, which had lower sensitivity and higher specificity. And another result is that the measurement of 7-hydroxyprogesterone in saliva showed a slightly better ability to differentiate between normal and altered 7-hydroxyprogesterone metabolite profiles with around a curve of 0.65 compared to 0.61. In conclusion, I'd like to say that measurement of cortisol and 7-hydroxyprogesterone are equally effective and interchangeable. These results highlight practical use, especially in screening chronic diseases as well as stress-prone groups. The non-invasive method of saliva sample collection minimize the impact of stress on the HbA axis. Thank you for your attention. I hope you find it interesting. I would be happy to answer your questions now.
Thank you very much for this interesting presentation.
Thank you.
Does anyone has any questions?
Maybe just a comment, that method would be very helpful in monitoring the patients with congenital adrenal hyperplasia, where you really have to monitor the 17-OH progesterone very often. Particularly, it's a problem in small children when it's difficult even to draw their blood, not speaking about the stress during the blood drawing. So if it really became more popular, that would be very helpful.
Does anyone has any questions? So I would like to ask you for your own contribution to this work.
So I took part in collecting database, analyzing data, and prepare this presentation. Thank you.
Thank you very much for this presentation. And let's move to the presentation number 7.
Yes, hello. I hope you can hear me now.
Yes, we can. Wonderful.
Oh, that's great. Thank you.
So this is the presentation number 7.
Yeah, can I share my screen with you, maybe?
Please do. I would like to read the title first so everyone know. So the title is Antenatal Corticosteroid Treatment of ELBW, VLBW Infants, a multi-center study in Podkarpackie province.
Yeah. I think you have to end. Oh, yeah. Okay. Can you see my screen now?
Yes, and now we'll measure the time right when you start.
Okay, so good morning and hello everyone. Again, my name is Aleksandra Skubisz and I'm 5th year medicine student at the University of Rzeszów. So in the first place, I may say it's a pleasure to attend this conference and I'm honored to share some of the work with you. So the topic of my abstract was about antenatal corticosteroid treatment of extremely or very low weight infants, multi-center study in Podkarpackie province. As an introduction, I would like to say a few words about the antenatal corticosteroid therapy. So ACT is recommended for women at risk of preterm birth from 24 to 34 weeks of gestation, unless there are contraindications. So either betamethasone or dexamethasone may be used. So you can choose one of 3 paths here with 12 or 6 milligram and 2 or 4 doses for each schedule. And if you give each of the recommended doses, you are giving a full course of steroids, which is the best quantity confirmed by medical studies. We also sometimes talk about the partial course, and this is a situation in which you have not administered 1 or more doses from the schedule. And the most important is the fact that optimal benefits are found in infants delivered within 7 days of last dose of ACT. And the second thing I want to say, because a common response to the subject of ACT in discussion is a reduction of risk of respiratory distress syndrome. And it is worth raising awareness about the other influences. So the last cohort analysis shows that ACT is also reduced the risk of perinatal and neonatal death, necrotizing enterocolitis, need for mechanical ventilation and systemic infections in the first 48 hours of life. And ACT is also likely to reduce the risk of intraventricular hemorrhage and may lead to a reduction in development delay in childhood. So the aim of our study was to describe the frequency of ACT and its impact on the occurrence of intraventricular hemorrhage and mortality of preterm infants treated in all 30 level centers in Podkarpacki province. So we conducted the retrospective observational multi-center study of all the infants born before or at 28 weeks gestation and less than or equal 1,000 grams. So we included in analysis 282 patients hospitalized from 2016 to 2020 in all 30 level centers in Rzeszów. So this study also enrolled infants treated in these centers who were transported immediately after delivery from lower referral centers. And we can immediately point out that the full prenatal steroids therapy was received only by 62% of these infants. But we can see the results from each center here, and the frequency of ICT used in patients clearly differed between them. I would particularly draw your attention that the percentage of ACT was significantly lower in premature infants who were delivered in lower level centers. And among these newborns, the percentage of ACT received was at 14% with full courses and 44% for partial courses, respectively, which is significantly lower than in the rest centers. And also, I would like to point out that the use of antenatal steroid therapy also varies between 30 level centers, even from 76 to 52%. So that's a huge difference too. And the absence of therapy increased the incidence of IVH with a significant statistical significance with p-value less than 0.0001, and it also increased the severe grade of IVH. And severe IVH is described as grade 3 or IVH complicated by post-hemorrhagic intraventricular dilatation or with periventricular post-hemorrhagic infraction. And we can easily see that the newborns with the lowest frequency of receiving steroid therapy are at the highest risk of experiencing intraventricular hemorrhage, and more than half of them will have severe IVH. And the frequency of ACT received is also reflected in the mortality rate. So once again, these two groups of the infants, which have the lowest percentage of full courses received, have the highest mortality from the first hospitalization. And this is statistically significant once again, with p-value less than 0.0004. So when evaluating the effect of steroid therapy on the odds ratio for severe IVH and mortality, statistically only two groups appears to be significant. But we have to remember that the entire group included in the study consisted of 282 patients. So by dividing it into so many subgroups, the size of the groups might not be sufficient to show significance. However, if I perform the same test on the entire study group, we get confirmation that not receiving full steroid therapy results in 4.11 increasing odds for severe IVH and 5.3 increasing odds of death from the first hospitalization. So in conclusion, I can say that increased use of ACT may reduce the incidence of IVH and mortality of preterm infants during the first hospitalization, especially in those delivered in lower level referral centers. So thank you for your attention, and I will be happy to answer any questions.
Thank you very much for this presentation. So do we have any questions? Yes, we do.
Thank you very much for your very nice presentation. I'm a neonatologist, so naturally I have some comments. It's very striking that the percentage of antenatal corticoids therapy is so low in this lower levels of neonatal or prenatal actually care. And did you try to find out what was the explanation why only such a low number of women were treated with antenatal steroids?
Yeah, I talked to the perinatal care doctors, and yeah, the most of them was afraid about the infections after giving antenatal steroids to the women, especially to this at risk of preterm birth, and they were worried about the sepsis after this. Yeah.
So for neonatologists, it's not very convincing because they prefer to have IVH, very severe hemorrhage inside the brain, instead of actually very poor explanation of sepsis, which is, if it has to occur, it will occur, but it's not because the antenatal steroids. We have to remember. Okay, thank you very much.
Yeah, thank you.
Any other questions? If not, thank you very much for this presentation. Thank you very much for the discussion. And it was our last presentation for this session. So all the submitted papers have been presented. We congratulate all the presented authors and participants of the neonatology and pediatric session. At this point, I would like to ask the president of the jury for a few words to sum up the session.
Well, I guess you mean me or anybody else.
No, our president of jury, Professor Tendera. Could you please switch on the camera so we can see?
Yes, of course.
Thank you very much.
Mm-hmm. Well, I generally think that was a very, very nice session. I learned a lot because, being a pediatrician does not mean you have to know all the topics, because now you concentrate on small sections. So for me, it was very instructive, and I think all the presenters were doing a great job. And I will have a problem in grading that, because, I would give the highest grading for everybody if it was possible. So please instruct us how we can do that, because I know I have this grading on my telephone, but I don't know if grading on a telephone will automatically show you our grading, or how will you present our grading?
If all the buttons are green, it's already sent, so I can see it automatically.
Okay, so
now it can be either yellow or green. If it's green, it's okay.
Okay, so we should do that now, I understand, or you will give us some time.
You have some time, but if it's green, it's already sent. So whenever you're free, just take your time.
Okay, so I guess we'll all need a little bit of time to really make the grading.
Of course.
It's really hard. As I told you, I will grade everybody the highest possible. Maybe somebody else would like to say something about this grading.
I have a technical question.
Yes, please.
Can we have could we use the half marks? I mean, 4.5?
No.
Oh.
That's the whole point.
It's difficult.
It will be difficult. All the presentations were really, really interesting.
Yeah.
And I would like
the session was really great.
So. I would like to congratulate all the participants, and thank you very much, Professor, for the words to sum up the session. We truly appreciate your valuable comments, accurate observation, and work on the presentation assessment. We would like to cordially invite you to the decoration and closing ceremony of the SIMC 2023 conference, which will be held in the A3 hall on the 19th of May at 4:15. So on the behalf of Student Scientific Society, I would like to thank you all for the participation in this session. Thank you very much, and see you again next year.